Welcome to another episode of DxTx Partners Podcast. I am very excited about today's podcast because we have our Chief Medical Officer, Dr. Ramis Gheith, and we have our Chief Clinical Officer, DxTx, Dr. Sheel Patel. But what really, not that I'm not excited for those guys, but we're really fortunate to have Dr. Timothy Deer on today. Dr. Deer is a leader in the field of interventional spine, helping transform the treatment algorithms for many spinal disease models. His research, teaching, mentorship has led to advancement in the area of minimally invasive spine, and his work on collaboration has led to a better understanding with pain, orthospine, interventional radiology, and neurosurgery. Lastly, Dr. Deer's work in product development and advancement has been impactful for companies such as ANS, St. Jude, Bioness, Spinal Modulation, Vertos, Vertiflex, Saluda, PainTech, Spinal Simplicity, Aurora, and Nirvonic. He's a technical founder of Axonics and is currently working on many new projects, and he resides in God's country, aka West Virginia. Dr. Deer, welcome to the episode. Quick question. Can you share a little bit about your career in interventional pain management and what your motivators were for entering this field?
No, great, Mike. Well, thanks for that introduction. I'm Tim Deer. I'm in West Virginia. I'm interventional spine. I've been doing this now for over 3 decades. I've been able to watch the field change and evolve. It's been a great ride, and seeing great people like my 2 other physicians on this podcast really rise up and see great practices out there. And what you guys have done at DxTx has been fantastic. And really, my journey, I went into pain. Really kind of in a strange way. I was originally going into neurosurgery over cardiology in med school. I was a fairly intense med student, getting ready to match in neurosurgery, and then cardiology came along with stents. And there was a turf battle between the cardiovascular surgeons and the cardiologists, and made me at the last minute switch from neurosurgery to cardiology. Got to UVA and didn't really like internal medicine very much. I was bored out of my mind, and found critical care anesthesiology. And then this new field of pain was coming along at the time, and the rest is history. I found it very exciting to be able to alleviate pain and try to help people. And that led to my current path to where I am today. So it's kind of I think a lot of anesthesiologists have that type of journey where you start one way and you make pivots, but the pivots have been certainly a blessing to me, and it's been a good ride so far. So hopefully, Mike, I got a few years left in the ride here. We'll see how it goes.
Fantastic.
Dr. Deer, thanks for joining us. Really appreciate you taking the time and out of your busy schedule to come on this podcast and give us some insights and some of your wisdom as one of the pioneers in pain medicine. This has really been a treat having you. So I want to ask you about the evolution of medicine and how we've evolved from going to a pain medicine fellowship, doing pain medicine for the last 2 decades myself, and watching it evolve into what we see today as a pain surgery field. What are your thoughts about that, and how did we come to this point?
Well, I think we're still, so thank you for that question. And, I've watched your journey there in St. Louis. You've done a great job, and it's been a pleasure to watch that. I think really we're still evolving. So I think we're about a third of the way through that journey where we're going. And I say that because when I came out of training, there was a new drug called OxyContin that had just been launched in Appalachia, where I am. And so I got to watch a confusion out there. People did pain, and there were pill mills and people that were poorly trained. And I really felt we need to separate ourselves at that point. The patients didn't know what we did. They thought we were all the same. They thought we were a chiropractor. They thought, and no offense to chiropractors, they thought we were a family practitioner with a sign that said, pill mill. And I really I noticed that interventional techniques work better than pills in most cases, right? And so I think a lot of people noticed that. And we started really looking at what we were doing and can we alleviate pain? And that's where neuromodulation really started having some serious research. So that was evolution number 1. It was really trying to find the answer to some of the addiction issues before people got put on medication. And then what happened was we found that a lot of people had, and sometimes rightly so, large spine fusion surgeries. And we saw a lot of those occurring. We saw a lot of black disc surgery. So someone would have degenerative disc disease and back pain. And we saw those people fail. And now the indications have changed dramatically. My spine surgical colleagues do a fantastic job now of selection, but the selection wasn't very good back then. And we really felt a need to do things more minimal. And that evolved into things like, Vertos and Vertiflex and things like the first generation of MIS. And then we saw those have some good results. And then we saw a need for a new evolution of things we could do to treat new disease processes like SI joint pain and, facet joint disease and things of that nature, vertebrogenic pain. And that new evolution came. So I think it's been this phased evolution of where we are today. And now the new evolution is going to be training people better so that we get better outcomes. And then generation 2 is collecting data with things like registries. And then the next generation is going to be, really looking very carefully at AI to help evolve new products. So again, I think we're a third of the way through that evolution to our field where we're going to go, but it's going to be pretty exciting. So that's a real general answer, but I hope that gives a little flavor of where I think we've gone so far.
That was great. Yeah, I agree. I couldn't agree more with the sentiments you've just mentioned. The pain surgeons are more and more frequently performing minimally invasive spine procedures today. Our field is no exception to that. Our practice here in St. Louis. I really do appreciate you mentioning the new fellows coming out and how they need to be trained up to where we are. And I've noticed that myself in our practice. So thank you for those insightful words. Thank you.
Dr. Deere, first of all, like Dr. Gheith said, thank you for coming on. And I know Mike said that as well. It's always good to pick your brain. I was lucky enough to do it a couple weeks ago in Charleston. I know we're going to try to set that up again. I have a couple questions, but I want to start out with kind of the timeline. We all trained at different times. You mentioned when you first came out, it was kind of when Oxycontin really hit the market. I was either fortunate or unfortunate to be in the middle of training when the transition kind of started, when the government hammer really came down on over medication. So I was able to see both sides of it. And like you, noticed immediately that not only do interventions work much better in the short run and the long run, but they work better when the patient's not already on opioids. They haven't been on long-acting narcotics or short-acting narcotics for a long amount of time, and our outcomes for those patients were much better. So it was a very easy transition when I started private practice to keep that going. I've been fortunate enough to work in a time where I've never really had to prescribe a lot of opioids. There wasn't government pressure and regulatory pressure to do so. Now, we definitely have had a change in what the patients are looking for. It's even easier today than it was 10 years ago when I started. But that being said, we notice when there are physicians that were trained in that time, when pain was the fifth vital sign and you were getting hounded to prescribe more medications, or you were, legally and medically liable, it's easy for us to pick up with new fellows and tell them these things and train them on these higher order procedures. How were you able to transition so well, being a part of both worlds? And how can we reach physicians that maybe have been practicing for that way, for quite some time, to try to get them to see what we see and be more of an interventionalist and less of a prescriber?
Great question. You were in West Virginia about the time that was transitioning. Dr. Kim and I, my partner, have been here quite a while together, and we used to inherit patients from family doctors, and they would be on a huge dose of drugs, and we would use procedures trying to get them off the medication because they weren't doing well despite these high doses. We know there's hormonal changes, there's changes immunologically, there's changes in so many things with the patient that are on those high doses. There's been at least 3 studies published. I've been part of 2 of those studies that have shown that devices, for example, do not work as well if your morphine equivalency is over 50 morphine equivalents a day. It just shows, and there's probably a neural change in the neuroplasticity of the body, and the receptors change the response rate. So that's a long answer, but the real answer is very, very simple. We got to be data-based, and data-based medicine will tell you that these opioids don't work in chronic pain. They just don't. They don't really work that well in acute pain after 3 days or so. I'll give you an example. If I do, a Minuteman procedure tomorrow, a Liberty implant, and something else, I'll give them 3 or 4 days of short-acting opioids, and most patients come back after day 3 or 4 and they're fine. They don't seem to be an issue with that. They do well on Tylenol and other things at that point. I think really we've learned that there is a place for opioids. It's for acute short-term pain, and there's no question about it. But we know long-term that we really need to base it on data, and that's why we have to keep building more data on the minimally invasive things we're doing, because we know we need, just like we held opioid we want to do the same thing with what we're doing. We want to hold that to a high standard as well. So I think we did show in the data that was the right thing to do. Now we're going to try to show in the data that the alternative to that is good for both pain and for function. I'm presenting in South America in a couple of days, and I'm talking about MIS to South American physicians, and I'm going to show outcomes on ODI and things like that, walking tolerance, more so than I show the pain scores. I think it's more important. So I think that's where we're going to go. So I think as long as we have that data, Sheel, we'll be able to, with good confidence, teach doctors this is the way to go. And we rarely start anyone new on an opioid in our practice. Almost ever. I saw 15 new patients today, and no one went on an opioid today because it really isn't the database way to practice.
Couldn't agree more. And I really like what you said there about functionality. Of all the new patients I saw today, that's one of the things that we talk about every time we see a new patient is we're not going to chase your pain, right? Because your pain score means very little to me except for to be able to trend it. But if you're able to walk 3 times as far as you could when you got here, we know your pain's better, right? So we want to chase that function instead of pain relief.
Yeah, I had a patient today that he had one back surgery and he actually had 3 levels of stenosis, and he got sent to me, and we talked about options like mild versus Minuteman, whatever it may be, Aurora Zip, 5-1, and we talked about SCS if none of those things were possible. But he told one of my nurse practitioners, Ashley, he told her that he went to the mailbox after dark because he didn't want his neighbors to see him on his walker because he was embarrassed by his functional decline. And I think when you have patients tell you things like that, you realize how important function is, not just for, them able to do daily activities, but it's also important mentally for them and who they are. If this guy had been a car salesman for 20 years, now he couldn't get out to his mailbox. So I think us, going back to the point you just made, us getting the function better is probably one of the best things we ever do in our field. And that should be our main focus in quality of life improvement is functional improvement.
Couldn't agree more. Thank you.
Dr. Deer, it's pretty obvious that the organization that you lead, ASPN, the American Society for Pain and Neuroscience, is at the forefront of addressing AI in interventional pain. Can you talk a little bit about what your vision is and how you see AI impacting our space in the near and distant future?
No, I love the question, Mike. Thank you for that. And AI, it's funny because when it first came along, I'm certainly not a young physician, not a training, and have some great young people in my practice. And people started to embrace ChatGPT and things of that nature. And we had a real confusion on what the term meant. You had some companies saying they had AI in their product, for example, but they really didn't. And so really, I think the definition, we just wrote a new consensus paper that Chris Massey led out of Austin, Texas, along with Usman Latif out of Kansas. And that paper defines what it means. There's so many terms in there you have to learn. So first of all, I think as part of ASPN is we define what the terms mean and make sure we're on the same definitions. 2 is we have to decide how we're going to use it. And so one of the things we're doing with our new AI division, which one of your DxTx members, Bobby Mogum, is one of the leaders of that. He actually is the chairman of that. I think John Prunts is the other vice chairman. That one of your members. We're going to have really a constitution of appropriate ethical use of AI. That's going to have to be really important in medicine, right? We have to make sure it's done for the right reasons, the right time. And a good example of that, I've helped a couple of companies recently design tools for MIS, and we use 3D printing along with AI to really to manage and design the products. And to think about that, that's really pretty amazing because a few years ago that product would have taken 5 years. It took 3 or 4 months now. So I think it's going to speed that up. 2 is I think it's going to help us learn algorithms of treatment and devices. For example, I had a device recently where my patient was able to touch their finger on a screen and then tell the device when it felt good or bad to them. The device is learning different combinations of electrocathode conformations to make sure that they're getting good coverage in the spine. So we're going to see it more in that type of thing. And then I think there's so many things that we haven't even thought about, like practice efficiency, how AI is going to help us with our documentation. AI will help us with our coding. It will help us with our pre-approvals. We know that there's companies out there, I won't mention my name, but you know who they are, who used AI against our patients. They've searched our medical records looking for wording that they can use to deny things, which is terrible. Denying patient access when it was appropriate to have it. We're going to use AI to help us with patient access. And so I think of all the things we're going to do in the short term, patient access is my number one personal goal. I think we need to really use it for that. And that will help us, number one, to help practice economically, but more importantly, it will help a lot of patients. So there's always, for every lover, there's a hater. There's always people. There was someone the other day that said some societies are embracing AI and, they shouldn't be embracing AI. I can't imagine why you think that. Whoever uses AI will win. You won't lose just by not using it, but if I have it and you don't, and I use it properly, I'm going to win. So I think it's really going to be important for us going forward that we all embrace it in an ethical way and find the proper uses.
Couldn't agree more. Dr. Gheith, Dr. Patel, any additional thoughts?
I agree. I think that Dr. Deere hit the nail on the head there. AI is the future. It's the future of medicine. It's the future of our industry. It's just the future of everything that we know today. I also believe the access to patient care allowing AI to help us achieve that level that we need to be at to provide that access to those patients is absolutely crucial, given that the other side is really trying to deny patient care and of course, deny patients a better quality of life. I do have one question for you, a follow-up question. I heard you mention quality of life and functional improvement and so forth with our patient care. How do you choose which patients will need the neuromodulation therapies going forward, and how does that play in your algorithm, particularly when we're talking about spinal cord stimulation or intrathecal therapies or PNS, for instance?
Yeah, it's getting great. It's gotten a lot trickier, hasn't it? So, two-part answer. Part one, I do think eventually what's going to happen is, going back to your AI utilization, someone will come in with a certain set of diagnoses codes, a certain finding on the exam. MRI will show this biomarker, and AI will say, based on all those things, the best chance of a good outcome based on registry data, which ASPN's going to build, is going to be this procedure first, right? So eventually we'll see that. It's probably 5 years away or less. It's not as far as people think in the future. And I think that'll be fantastic. But you need a good registry to give you that data. And you have the Medicare data bank, you have the payer mix data bank, and now we're going to have some society data banks. So it's gotten more difficult to pick that. There's a commercial I'm going to put on social media sometime soon. I shot like 11 years ago for the Super Bowl in West Virginia. And I talk about, we have spinal cord stimulation, peripheral nerve stimulation, and mild to get you off opioids. And that was, probably 2014 or 15. And now I think about it, I got so many other tools, right? So you have all these options. And so some days I'll have new patient day and I'll have a visiting physician, and we'll have, two patients come in with CRPS type 1 or type 2 of the lower limb. They have a normal spine. They're a great DRG candidate. So it's like, oh, that's an easy decision, right? They've already had PT. They've already had injections, things of that nature. Then there'll be some coming, they've had 2 back surgeries. Now their pain is radicular down their right leg. Their MRI shows epidural fibrosis, and they failed, other things. So again, a good stimulation candidate. So sometimes it's just pretty easy. And then the last candidate I think is pretty easy for me now is diabetic neuropathy patients come in and they're on medication and they're still having severe pain in their feet and they aren't doing well. That, to me, we're going to SCS in those patients almost always, right? So there's some people that are pretty easy choices. The hard choices are someone comes in and they get an MRI and they have modic changes at L3, 4, 5. They have discogenic type pain. They have a disc that would be fitting for something like intradiscal Vivex. We have the Restore study we're running now nationally, a big level 1 RCT. They have stenosis, both centrally and foraminally. They have SI joint disease. And then you have all these different comorbidities, and you have to decide what's first. And we know there's a study distinct showed that SCS works for non-surgical back pain, and they have no surgical correctable lesion, but they have a lot of things we could do with MIS. So I think in those situations, the way I handle it, and you and I probably have very similar methods, I would guess. I say, so, Ms. Jones, what's affecting your life the most? Oh, what's affecting my life the most is I can't walk. If I walk 100 feet, my legs go numb and weak and I can't walk. Well, then I'm going to treat the stenosis first. If she says, oh, I can't sit down and do my evening, I can't read the paper, but setting is really painful, and when I've been for it, it kills me, I may treat the discogenic disease first. If she says, it's everything, and it's hurting my waist down all the time, I may go to SCS first. So I kind of base it on what's affecting the quality of life the most and treat it in that direction. But every single patient, and I think Dr. Sheel, if you've seen me do this, I go and draw out for them all the things that are going on and what the options may be, so we don't surprise them later when we treat one thing and there's still something else. Because as a patient, it gets depressing when you treat one thing, but then they still can't function normally. So that was a long answer for you, but it kind of goes to show the complexity of where we are today, trying to make those decisions. And I think it comes down to the simple SCS candidate, DRG candidate, PNS candidate, upper extremity, ulnar nerve injury. I might go do a PNS right away because I don't want to go in the cervical spine if I don't need to. Those are easy. Intrathecal drug delivery is harder. We used to do a lot of it. We haven't needed to do as much anymore. We've had such good success with SCS and DRG and PNS that our number of intrathecal drug delivery patients have really dropped off from maybe 50 new patients a year to really less than 10. And now many of those are metastatic cancer patients in our practice who need intrathecal drug delivery. So we don't really have as many patients to choose from because our success rate has been much higher with non-intrathecal therapies.
Thank you for that. It's very insightful. And yeah, it reminds me of an email that I sent out last week or so about choices and how do you choose and how do you help the patient make that decision with all the therapies that we have? Fantastic therapies. Thank you.
Dr. D, I'm going to shift gears just a little bit here. I've been in healthcare for over 35 years, working with physicians my entire career. One of the things that is very real now that I've noticed, and probably maybe escalating a little bit, is physician burnout. And when you think about all the changes, the challenges, the pressure, the staffing, the insurance companies and peer-to-peers and everything that people face, it's a very real issue. And we have physicians in our network all across the spectrum, people just coming out of fellowship, people that have been in the field for 30 plus years. Can you talk a little bit of how you've managed through physician burnout and any advice for any of our young physicians or even our physicians that have been a while that are seeing the change, how they can manage burnout?
Man, that's a great question. It's funny, we see people right now on LinkedIn, a couple of people post about physician suicide pretty often, right? You read those posts, you're like, dang, sounds familiar. I know this person, so it is a very challenging thing. A lot of doctors I know that are in their 50s and 60s want to retire early because they really hate their life and they get frustrated with the insurance companies and other things. And many young doctors come out thinking they're going to make a fortune. And then what they find is, they're working hard and they're having trouble getting approval for things. And they still may make a lot of money, but they hate their life because they're working on Saturdays and they're working late every day and they haven't done their paperwork. And so, they realize money's not everything in those situations, right? So it's all those things that you mentioned. I think there's two things I've done. So first of all, I'm not burned out at all. In fact, I love every day. If I stay healthy, I'll practice till I'm 80. So I have zero burnout. And it's the most exciting time to be in our field ever. This is the golden age, but it's the beginning of the golden age because it's been the golden age for about 15 years now. It's going to continue of us doing cool things that help people, right? So how do I recommend not getting burnout? Well, I think there's two things you can do that will help you. And I don't know if Sheel remembers this. I was preaching the same things a few years ago when Sheel was a med student in West Virginia. One is, I think you have to get your priorities straight in your head, right? And whatever that is for you, is it God, family, work? And you don't put work first. So you have to have time to dedicate yourself to spirituality or your family, whatever it may be. And part of their family's exercise. If you don't exercise, you're going to have a heart attack and die, and your family's not going to have you. So you got to make exercise a priority. So that's number one. Number two is time management. I think the reason I'm not ever burnt out is like this morning, my alarm went off at 5:10. I'm running with friends at 5:45, 6 o'clock. I'm back getting a shower, starting work. And during work, I've got a few calls like this, and I enjoy things other than just doing procedures, right? So we have a few things like this where we share ideas with friends. And then, you go home and you have your dinner and you have to do something fun. But I have my day managed pretty well so that I have time to exercise, have fun, and share time with friends. And I enjoy my work colleagues. I think it's important to make sure that when you come to work, you're happy. I like Mondays. A lot of people say, I hate Monday. I kind of like Monday. I get to come to work, get to do things, do procedures, see people. So I think it's those two things, setting your priorities straight and managing your time in an effective way. And then whatever that is that makes you happy, whether it be exercise, whether it be, meditation. I can't imagine that sounds terrible to me, but meditation, whatever it may be, do those things because, man, life's short. And if you don't do it, you're going to get some awful disease and die. So do it while you can, because you may not be able to do it tomorrow. And hopefully we'll keep doing it as long as we possibly can go.
That's fantastic. I was energized just listening to it, not even a position. So fantastic.
Just loved it. Loved it.
Well, DxTx is very involved with ASPN. We're fortunate to have some of our physicians on committees, part of your AI. Can you tell us about what do you guys have planned in the future? Any exciting happenings that you'd like to share?
Yeah, no, I think there's a lot of things I can share here as we get near the end of this podcast. First of all, anybody in your group, and I've had this discussion that wants to get involved, we're going to find a place for you. The thing, when we started the society, Dahlwood and I, in 2018, we had our first meeting later that year in Aspen, Colorado. We had 80 people. And people were like, why isn't the society? We want a society where young people would have a place and older people would have a place, and there'd be mentors and people could get together. So anybody that wants to be involved, whether they be in their 30th year of practice or their first year of practice, we're going to find a room for you to work with us on some project. Two is, if you have a great idea, we're going to do that. So yes, what's coming forward? I think this AI division is going to be a great thing. It's going to be a big thing for us. We're going to have AI partners with different corporations around the globe to really advance medicine. So that's going to be one thing you're seeing us launch it, but we're not going to launch it and forget it. We're going to launch it. It's going to become fantastic. MIS certification. It's funny. We started that program in two other societies. Suddenly had a certification program. It's going to be a real certification program. Dave Dickerson is a fantastic leader. He was chairman of ASA for 4 years, as was I. And he's going to lead that program with David Lee and, Scott Prisloff, a bunch of great folks who will be involved in that. Ashley Bailey Clausen, Anthony Graffiti. I could go on and on. And we have several surgeons, Angel Boev, neurosurgeon involved in that, Pierce Nunley, ortho spine. So we're gonna really have a certification program where people get mentored. They'll get to share their cases with their mentor. They'll get to come visit their mentor and watch their mentor do cases. And then they'll have a hands-on exam ran by Pankaj Mehta and others. And they'll have a written exam by Togo Salva, the director of Rush Pain Fellowship Program. So it's going to be a true certification program, and then they take that back to their credentialing committee, to their insurer, and others that they've gone through the program, and not just some one day thing or whatever it may be. So AI, MIS, the registry. We just had an RFP for registries. We had so many great proposals. We're going to narrow that down to 2 over the next few weeks, and we'll create the first ever society-based registry. There's been some other in pain, the pain spine world. People have tried it; they've all failed. We're not going to fail because we're going to, again, partner with industry to help us make sure we capture those cases and we have good support for the engineering part of it. That's where the registry usually fails, is the engineering process of it. So that's going to be a big deal. We're going to be in London for ISPN. Probably I expect we'll have over 500 people there. We'll be back in Miami every year in July. We're never leaving Miami. Just so you know, we've re-signed to 2030 in Fontainebleau. We don't want to go any bigger than that. We don't want to go to a convention center. We want to stay there so we can network and share ideas. And then lastly, I think one of the most exciting things to me, and one of really a couple of folks that work with me currently, Anu Shaw, Lucas Bracero, Marcin Kars, Vinny Franco, with this new Young Innovators program is the lifeblood of our society. We had almost 1,000 people last year, 5 years in practice or less, or in training in Miami. I think that of all the things that excite me the most, though, it's that program, the Young Innovators program, to properly train people and properly mentor people and let them mentor each other to make themselves better. To me, that's going to be the future there. And then lastly, our guidelines program continues. We just published a 60-day PNS guideline, an AI guideline. The next thing you'll see is a neuromodulation for critical limb ischemia guideline coming out that Sean Pri is running down in Texas. That's going to continue to come. Those guideline projects will be coming as well. So hopefully that'll continue to evolve and be updated. So that was a lot of stuff. So I could go on for another hour with stuff, but those are some of the things that excite me the most.
Yes, it's super exciting. And one of our young doctors, Matt Greca, is involved in that program with you.
Yeah,
so,
Matt's doing fantastic. I've asked Matt to do 3 or 4 projects with me, writing-wise, and he's done such a fantastic job. And so the Fort Lauderdale community is really blessed to have him down there. And he's working with my good friend Kevin Carnes, as you know, in that group.
yeah.
And so what a fantastic group of people down there. So you guys are really just impressed me all over the country.
Yeah, we're really excited. We have fantastic clinicians. Dr. Patel, Dr. Gheith, any final questions as we wrap up?
I have one quick question. So when I was a resident, a pain fellowship was by far the most competitive anesthesia fellowship. We had a few people coming in from PM&R, maybe neurology had started at that point. I think psychiatry was working on starting a pain fellowship. With the demand for anesthesia, what we've seen is most residents don't want to do any fellowship. When I was a resident, it was, well, if you don't do a fellowship, you're probably not going to be as good as you should be at your job. It doesn't seem like that's worth anyone's time at this point because they're getting signed for full-time anesthesia contracts in their first and second years of anesthesia at really good salaries. You talked about us being at the beginning of the golden age, which I completely agree with. How is that affected by the lack of pain fellowship spots that are getting filled? And when do you see the pendulum swinging back the other way? Because I feel like there's not enough of us as it is. And over the next 5, 10, 15 years with these advancements that are coming, are we going to have enough really well-trained pain surgeons to be able to deliver the care to all the people that need it?
Dr. Patel, that's a great question. And I think, there's so many landmines in this question I can step on. I may kind of offend a few and inspire a few in this answer. So I'm just going to answer it like I always do. So if I inspire you, great. If I offend you, just toughen up, whoever you are. But so the answer number one is, I came out of anesthesiology and then did pain at UVA and had great mentoring with John Rawlingson and the team there. And I practiced anesthesia until I finished my pain boards, my anesthesia boards. In January 2nd, 1996, I walked out of the hospital and I said, man, I'm never doing that shit ever again, right? And I never did, because I didn't want to do anesthesia. I wanted to do pain, right? So first of all, you have to ask yourself, if you're an anesthesiologist and you can make $500 a year, or you do a pain fellowship and then get a pain job making $350 or $400, you ask yourself, why would I ever want to do that? Well, it's the specialty of pain medicine. It's a different specialty. So you have to ask yourself, what do you really want to do with your life? And, short-term money, I've seen anesthesia do this my whole career. There'll be too many anesthesiologists in 3 or 4 years. I've seen it 3 times before. And then the rates will go down and the residents won't get a job and they'll go back and do their fellowship. That's what you're talking about. I think what's going to happen is the PM&R residents that are getting into fellowship now are going to get better and better. In fact, I've mentored a lot of PM&R residents over the last few years. I have one coming from Miami again here next month with me for a week or two. And when I do that, what I find is the PM&R residents right now, the skill levels there are best they've ever been. I compare it to PM&R 25 years ago, that people now are so much more skilled and talented, and they're going to get really good. And then the anesthesiologists who go back into pain fellowships down the road are going to get really, really good. So I'm optimistic. I think both groups are going to do fantastic. I've had 2 emergency medicine doctors recently go into pain that I was able to meet and talk with and see them and their work, and they both are fantastic. So I think that the quality of people is good. Now, what the problem is, and you've heard different people write about it, no one has a solution. They can say they have a solution all day and they're all wrong. Is the fellowship in 1 year just isn't enough time to be a good MIS surgeon, right? And particularly when you have to go rotate, and no offense, through psychiatry and neurology and, rehab, when you have to go rotate through all this stuff that you're never going to do, quite honestly, it's good to know about those things. You can't really be a good MIS surgeon when you exit fellowship. You just can't. There's a few programs, which I won't name, that you're going to be pretty good, but everything else, you may have good basic skills. So the real problem is going to be people want to make that 2 years. No one wants to do 2-year fellowship. So the non-ACGME fellowships that are being established around the country right now are probably going to take over in a lot of places, because they're going to get trained to do minimally invasive spine, patient selection, complications management. And that's what the job market is going to demand, because there's going to be that need you mentioned. So I think what you're going to see probably is either the failure of ACGME fellowships around the country over time, which I hope that isn't true, but I'm worried, or you're going to see an evolution to an MIS-based fellowship that's either ACGME accredited or it remains non-ACGME accredited with really talented people. And that's why we created this certification program, because if you come out of one of those really good ACGME fellowship programs and you learn SCS, but you didn't learn SI fusion or posterior lateral arthrodesis, or posterior arthrodesis, or anything we're doing, facet fusion. Next thing you're going to see go like this is going to be facet fusion, which we're working on a project right now. We can then find a way to teach you that where you actually get mentored, and not just one weekend course, but you get mentored by someone over time. So that's going to be the answer to that. But that was a long answer. Again, I keep answering these with long answers, but none of these questions you're asking are very simplistic. They're very complicated questions. So the summary of that answer is we're going to be fine. The physiatrists going into pain are going to do a great job. The anesthesiologists who come back into pain are going to be fine and do a great job. And I think we'll have enough people because the demand will drive us there. But fellowships will have to change, and the post-fellowship training is going to have to change. And we need more mentors. So the 2 of you, I hope you join me in mentoring younger people and show you were a young guy. You're not as young as you were. Now you're going to become senior to a lot of people just coming out of fellowship. So you're going to take that role now away from me. And I love that, right? And, I think that the CMO and the CCO already here with me today, you both are already doing that, but we need more people to do that mentoring.
Understood. Thank you.
Thank you so much. Dr. Timothy Deere, national leader in interventional spine. Thank you so much for joining DxTx Partners Podcast. Very informative. Dr. Gheith, Dr. Patel, always a pleasure. Love listening to you guys. Thank you very much.
Thank you, Dr. Deere.
Thank you, guys.
Yeah. Dr. Patel, thank you so much for having me. And Mike, it's always a pleasure to see you again. So thanks.